Looks like we're getting a steady flow of people logging on. We'll give it 1 minute. Well, it's 6:45, a little after, and I think we have a pretty good quorum. So, good morning and welcome to the University of Washington Department of Orthopaedics and Sports Medicine Grand Rounds. You may have noticed I am not Howard Chansky, who has been predisposed to a quote-unquote early start at the VA. I'm Clayton White. I'm professor of orthopedic surgery and sports medicine here at the University of Washington, and I'm on faculty at Stancil Children's Hospital. This morning, I have the pleasure of introducing Dr. Todd Blumberg, assistant professor of orthopedics here at University of Washington, and a faculty member with me at Seattle Children's Hospital, and also one of our esteemed fourth-year residents, Dr. Ryan Stancil. Today, they will be presenting developmental dysplasia of the hip in the adolescent and young adult. I think it's a talk that has a little bit of something for everyone. Ryan will be introducing the topic of hip dysplasia from infancy to adolescence, physical exam and imaging findings. And then Dr. Blumberg will be taking over management for adolescent dysplasia and discuss treatment with periacetabular osteotomy, along with some technical aspects of the procedure, review the literature, complications, outcomes, and controversies. So without further ado, I will turn the microphone over to Dr. Stancil. Enjoy.
All right, good morning, everyone, and thank you, Dr. White, for the introduction. We're talking about developmental dysplasia of the hip in adolescents and young adults, management and controversies. Dr. Blumberg and I do not have any relevant disclosures. A bit of an outline of where we're going today. First, I'll talk about developmental dysplasia as a spectrum of disease throughout development. We'll talk about the specific deformities involved and the pathomechanics involved. And then we'll talk about diagnosis and evaluation of the adolescent hip. Developmental dysplasia is a common issue. It's diagnosed in 1 in 100 births, and 1 in 1,000 have a congenital hip dislocation. Some risk factors involve breech presentation foremost. 3% of newborns are born breech, but interestingly, 16% of infants with developmental dysplasia of the hip are breech presentation. Additionally, female sex, family history of developmental dysplasia, and oligohydramnios are other mitigating risk factors, in addition to some ethnic differences in genetics, as well as swaddling practice, among other risk factors. Newborn screening is a widely accepted practice via newborn examination. The Barlow maneuver tests the hip in adduction, 90 degrees of flexion, and neutral rotation, where a downward force subluxates or dislocates an unstable hip. The Ortolani maneuver is the opposite. In an abducted hip, an anterior force is directed on the femoral head to reduce an unstable joint. The Galeotti test additionally suggests a dislocated hip with a unilateral shortened appearing femur. Ultrasound screening is recommended at 6 weeks of age in all neonates that have breech presentation, a family history, an abnormal exam or equivocal exam, or if there's concern for improper swaddling techniques from the family. Here we have a screening ultrasound of a normal newborn hip. The alpha angle measures acetabular inclination between a line drawn through the ischium here in red and a line drawn through the acetabular roof here in blue. Here our alpha angle measures 62 degrees. Anything over 60 degrees is considered normal. Additionally, we can assess the percent coverage of the femoral head by measuring the percentage of the femoral head diameter under our ischial line. Here it's 55 degrees, and anything over 50% is considered normal. Here's an infant with a subluxated dysplastic hip. The alpha angle is 42 degrees, and the femoral head is 29% covered. And then here is a frankly dislocated hip. Based on when developmental dysplasia is diagnosed, age-appropriate treatments are available to try to restore normal skeletal morphology by the time of triradiate cartilage closure. This patient with a dislocated left hip was treated in a Pavlik harness and later a Rhino Cruiser abduction brace, who later had a stable, reduced left hip with some residual dysplasia. This is after treatment in a Pavlik harness. Patient was surveilled until age 4. She's got some residual dysplasia on the left, but a reduced congruent hip. She was released from surveillance at that time. Advancing age requires more invasive treatment. This infant at about a year of age required closed reduction in spica casting with an injection of radio-opaque dye to confirm concentric reduction. If closed reduction fails, an open reduction may be required as multiple soft tissues, including the hypertrophied acetabular labrum, become interposed and block reduction. Pelvic osteotomy may later be required to improve femoral head coverage and stability. There are numerous surgical techniques to accomplish this that are beyond the scope of this talk. But again, overall goal is to get to normal skeletal morphology by skeletal maturity. Older children with chronic dislocations may additionally need a femoral shortening osteotomy to accomplish reduction in addition to their pelvic osteotomy. Treatment options obviously change with skeletal maturity. This is the same patient that was treated with a Pavlik harness and surveilled until age 4. She had some residual dysplasia at the time and did not follow up until recently. Now at age 16, she has left hip pain and dysplasia. Conceptually, is this residual dysplasia from childhood or did it develop later on in life? This is obviously residual dysplasia that persisted despite treatment. Either way, these patients ultimately fall into the same diagnostic and treatment framework. So why do we ultimately care about developmental dysplasia of the hip? Because the anatomic differences in the dysplastic hip cause abnormal biomechanics that degrade the native hip over time. The acetabular rim is overstressed, and the abnormal morphology of the hip causes excessive shear forces that accelerate chondral degeneration. DDH, along with other pediatric hip problems, have long-term consequences for hip health, as a large percentage of osteoarthritis, particularly early arthritis, can be traced back to a developmental diagnosis. Based on this data, nearly 50% of patients with a known pediatric hip diagnosis have radiographic arthritis by age 50. Here we'll talk about the segmental deformities of hip dysplasia. It can be broken down to the acetabular side, the femoral side, and the soft tissues. The acetabulum is foremost shallow and elongated, as we can see here in this 3D model. This increases the shear forces, as previously mentioned. There are often associated insufficiencies of the acetabular walls. Anterior insufficiency is most common, but it can be in any or all directions. The acetabulum can also be relatively retroverted. This can be globally retroverted or from relative posterior wall deficiency. It's also important to recognize femoral deformity when treating these patients. The femoral head is often small and aspherical. The neck is valgus. There's increased aneversion and decreased offset. Additionally, there can be concomitant cam lesions causing secondary impingement. As mentioned when discussing hip dislocation in infants, there are numerous soft tissues in the dysplastic hip that can block reduction of the femoral head. One of these is the enlarged acetabular labrum. As the bony acetabulum is shallow and does not provide enough containment to allow for a congruent joint, the labrum enlarges during development in an attempt to make up for that soft tissue constraint. There may additionally be a thickened hip capsule. As the labrum compensates to provide a more static constraint to the insufficiently congruous acetabulum, so do the dynamic constraints of the hip joint. The gluteus minimus in particular must work overtime to keep the hip centered in the acetabulum during the gait cycle. As seen in the radiograph in a patient with developmental dysplasia, the minimus tendon has actually deformed the superior femoral head. The insufficiently congruous joint leads to micro-instability of the hip during the gait cycle. The excess motion causes stress on the enlarged labrum, leading to painful tears, cysts, and inflammation. As there's typically anterior wall insufficiency, as the hip comes into extension, it can excessively translate anteriorly, leading to anterior groin pain. In a patient with posterior wall deficiency, they may have abnormal kinematics during hip flexion, causing vague sciatic symptoms or impingement type complaints. In this conceptual diagram, we can see a force directed over a large surface area leads to improved pressure distribution. When point loaded, however, our infrastructure is unlikely to tolerate such forces. On the left, we see a normal hip with distribution of joint reactive forces during weight bearing on a large surface area of the weight bearing dome of the acetabulum, compared to the dysplastic hip on the right, which is point loaded at the lateral rim, causing it to fracture. Radiographic evaluation of the young adult hip is paramount in assessing the spectrum of deformity. First, we must ensure that we have quality radiograph. The coccyx should be in line with the symphysis and within 1 to 3 centimeters of it. The obturator foramen should be symmetric. We should be able to easily see our iliopectineal and ilioischial lines, as well as our anterior and posterior walls, as well as our teardrop. Proper radiographs are paramount in accurate assessment of acetabular version, as altered tilt or rotation can mask or accentuate deformity. Finally, we have the sourceal, the weight-bearing dome of the acetabulum. Special attention should be paid to the medial and lateral borders of the sourceal, as we will see when assessing the severity of dysplasia. It should be differentiated from the supralateral rim. There are several options available for orthogonal views. The Dunn 45-degree, 90-degree, and frog lateral all allow us to assess femoral neck head offset and any signs of concomitant impingement from the proximal femur. The false profile view allows us to further assess acetabular morphology. The foot of the affected hip is placed parallel to the cassette with the pelvis rotated 65 degrees. Two of the most prognostic radiographic measurements are the lateral center edge angle and the tonus angle, or acetabular index. The lateral center edge angle is the angle between a line through the center of the femoral head that is perpendicular to the teardrops or ischial tuberosities, and a line through the center of the head and the lateral border of the sourceal. A lateral center edge angle of less than 20 degrees is dysplastic, while 20 to 25 degrees is borderline dysplasia. The acetabular index is measured as the angle between a similar horizontal line and a line drawn through the medial and lateral borders of the sourceal. Greater than 10 degrees is considered dysplastic. The lateral center edge angle has been shown to be an important prognostic indicator for hip health. In a series of studies, no patient with a lateral center edge angle of less than 16 or an acetabular index of greater than 15 made it through the 7th decade of life without end-stage osteoarthritis. There's additionally a 21% increased risk for progression to total hip arthroplasty for each degree of lateral center edge angle less than 28 degrees. Additionally, of 710 hips that underwent total hip arthroplasty before age 50, 48% had a lateral center edge angle of less than 20 degrees. Here is our patient, as our 16-year-old patient that we previously mentioned, with lateral center edge angles of 13 and 16 degrees. The anterior center edge angle off the false profile similarly measures anterior under or over coverage of the femoral head and is the angle between a vertical line through the head and a line through the anterior sourceal. Values under 20 degrees are indicative of dysplasia, while 20 to 25 is borderline. angles over 40 degrees are conversely indicative of overcoverage pincer type deformity. And here is our patient with similarly signs of dysplasia on the false profile view. Additionally, we can measure percent under coverage or extrusion index, where anything over 25% is abnormal. The femoral head can be lateralized as measured by this white line, or start to become incongruent as seen in the left hip. Severely dysplastic hips may additionally have a broken Shenton's line, as similarly seen in our infant with a dislocated hip. Acetabular version can grossly be assessed by observing the crossover sign, whether the anterior wall crosses over the posterior wall on the AP radiograph. With more severe retroversion, the ischial spines may become visible on the AP radiograph. On the lateral radiograph, we can assess it for any signs of potential impingement at the proximal femur. A circle is drawn congruent with the femoral head. An angle is measured between the line parallel with the head-neck axis and where the bone is first visible anteriorly outside of our sphere. An alpha angle over 50 suggestive of head-neck offset issue and a potential source of impingement. Advanced imaging is also a mainstay evaluation of the young adult hip. Our same 16-year-old patient underwent an MRI arthrogram of both hips, showing bilateral labral tears as well as some cartilage degeneration on the left side. While these studies have traditionally required arthrograms, newer 3 Tesla MRI scanners have shown to be sensitive enough to pick up this pathology without needing the painful and invasive arthrogram. Cartilage mapping can be used to evaluate these patients. T1 MRI images shown above on the reference patient show superior labral hypertrophy with a tear and paralabral cyst formation in a 27-year-old female with a dysplasia. 3 different cartilage mapping techniques are shown: degemerate index mapping, T2 star mapping, and T1P mapping. The red degemerate imaging shows decreased glycosaminoglycan content. The blue indicates decreased collagen content and increased water content. And the red in the T1P mapping shows decreased proteoglycan content and cartilage. The degemerate imaging on the left is the most widely studied technique, but requires contrast administration, while the latter 2 do not. CT scans using an young adult hip protocol are increasingly important to evaluate these patients to assess previously under-recognized acetabular and femoral deformity that can be causes of secondary impingement. Here we see in this patient, they actually have relative femoral retroversion on both sides. And our 3D imaging shows relative anterior and superlateral under coverage of the acetabulum. We're also able to get 3D renderings of femoral version. I don't see one to play. When evaluating these patients in the office, they have some or all the following complaints. They may have abductor fatigue, which may present as lateral hip pain. They can have anterior pain from rim overload or micro instability, or pain with impingement, particularly with hip flexion activities. 77% of patients present with a Trendelenburg gait. They generally have a normal range of motion that varies with any coexisting impingement. It's also important to assess for ligamentous laxity in these patients, as 40% of children with developmental dysplasia of the hip have a positive Beighton score, as opposed to 7% without developmental dysplasia. Those with impingement type pain will often have pain with flexion and internal rotation, as seen on the left. Those with instability may have symptoms with extension and external rotation, as seen on the right. And from here, I'll turn it over to Dr. Blumberg.
Thank you, Ryan. Good morning, everybody. And Ryan, thank you for an excellent and thorough introduction to the topic. Objectives for the second half of Grand Rounds are to discuss the management of acetabular dysplasia in adolescents and young adults, as well as review the major steps of a periacetabular osteotomy. I will touch on some of the recent literature regarding anticipated outcomes, complications associated with the procedure, as well as current controversies in hip preservation. Initial management for patients presenting with acetabular dysplasia remains a trial of non-operative treatment. Anti-inflammatories, physical therapy, activity modification, and steroid injections may improve or substantially relieve symptoms. Surgical management is reserved for those that do not respond to non-operative treatment and classically would involve correction of the underlying deformity. For adolescents and young adults with hip dysplasia, a reorientation of the acetabulum with a periacetabular osteotomy is performed, and depending on other findings, may be combined with other procedures to address labral tears, cartilage injury, or CAM lesions. For patients with substantial proximal femoral deformity, an intertrochanteric osteotomy may also be indicated. Severe Perthes-like deformities may benefit from a surgical dislocation approach and trochanteric advancement prior to PAO to improve offset and abductor mechanics. Indications for performing a PAO are hip pain in the setting of acetabular dysplasia with closed triradiate cartilage. As Ryan previously noted, an upsloping sourceal with an elevated tonus angle over 10 degrees and a center edge angle under 25 degrees are widely accepted metrics in diagnosing hip dysplasia. It is critical that the hip and cartilage is healthy with only minimal subchondral sclerosis or joint space narrowing allowed. Once subchondral cysts are present, the success of the procedure becomes quite limited. As familiarity with PAO has increased since it was first introduced in the late 1980s, indications have evolved to address other deformities such as acetabular retroversion. Age is not a true contraindication to having a periacetabular osteotomy. While adolescents and young adults are perhaps the most likely to benefit from PAO, the condition of the hip, specifically the lack of any degenerative changes, is really what guides whether a hip preserving procedure may be indicated. The overarching goals of surgery are to correct the deformity and improve, or even perhaps resolve the abnormal biomechanics that are leading to changes that can herald arthritis. By improving stability and avoiding impingement, a PAO can preserve the native hip for decades, delaying an arthroplasty or preventing it entirely in some instances. Secondary goals are to avoid creating another problem, that being impingement, which is surprisingly easy to do during correction and reorientation of the acetabulum. Careful assessment of preoperative motion and post-correction motion is helpful to avoid this complication. Like anything in orthopedics, a well-thought-out preoperative plan is key. Preoperative MRI to assess for any intra-articular pathology is critical, so a plan can be made prior to the time of surgery. Any proximal femoral deformity or clinical exam suggestive of a torsional deformity should have a preoperative CT to better assess. A combination of straight and angled chisels as well as radiolucent retractors aids in safely performing the procedure. Coordination with anesthesia ahead of time for regional block and utilization of tranexamic acid and cell saver is helpful. Long 3.5 or 4.5 millimeter cortical screws beyond the typical length in a small or large fragment set are needed as well. Speaking of femoral deformity, they're surprisingly common, and which ones need to be addressed are quite controversial. The presence of comorbid FAI is extremely common, and having a plan for possible treatment should motion be restricted after correction is important. One study found that proximal femoral deformity was present in over 90% of patients with hip dysplasia, highlighting the importance of appropriate preoperative 3D imaging. The technical part of the procedure was initially described by Gons and colleagues in 1988. He described osteotomies of the ischium, pubis, and ilium with subsequent reorientation of the acetabulum. Unique to this procedure and separating it from a triple osteotomy that is performed for patients with open triradiate cartilage is that the posterior column cut is incomplete. This allows for improved stability and faster bony healing. The osteotomy of the posterior column is performed at an angle of about 120 degrees from the iliac cut, directing it towards the initial ischial osteotomy. The posterior column osteotomy is typically performed so about 2/3 width of the posterior column is on the acetabular side. The patient is positioned supine on a radiolucent table. The ipsilateral arm is positioned with the elbow flexed and secured out of the way to allow for easier access to the posterior column cut. The entire hindquarter is draped free. Preoperative range of motion is checked under anesthesia. Limitation to flexion or flexion plus internal rotation should be considered a problematic issue and it may be worsened after correction is performed. A modified Smith-Peterson approach is utilized to gain access to the hip. The external obliques are elevated off the iliac crest with electrocautery as a sleeve for later repair. After elevation of the obliques, the TFL fascia is incised in line with its muscle fibers, which is approximately a 30-degree oblique trajectory inferolaterally from the ASIS. This plane allows safe access to the direct head of the rectus and hip joint, protecting the lateral femoral cutaneous nerve. The rectus is mobilized laterally and the interval between rectus and iliacus is exploited. The rectus tendon is followed up to the inferior spine. Next, the anterior superior iliac spine is osteotomized, and the remainder of the exposure can now be completed. The goal of the exposure is to access the interval between the iliopsoas tendon and the hip capsule, a potential space that allows for easy access to the ischium and infracotyloid groove, the starting point for the ischial osteotomy. The ischial osteotomy is guided by fluoroscopy, but tactile feedback with the osteotome aids in performing the osteotomy. The angled chisel is initially started over the medial third of the ischium. It is then recentered and re-impacted centrally and finally laterally. Extreme caution is exercised laterally as the sciatic nerve exits the notch nearby. The leg can often be brought into a position to help relax the sciatic nerve with hip extension, slight abduction, and a little bit of external rotation to aid in relaxing the nerve away from the ischium and osteotome. Next, the pubis osteotomy is performed, just medial to the iliopectineal eminence. As Julie saw, our osteotome can be utilized at the surgeon's discretion. With the ischium and pubis osteotomy is completed, a small window is then made subperiosteally in the outer table of the ilium, approximately at the level of the distal portion of the anterior superior iliac spine. Fluoroscopy is typically brought in and the trajectory is verified for the posterior column osteotomy using the start point for the fourth and final cut as the guide for the trajectory of the third iliac osteotomy. A reciprocating saw is used to perform the first portion of the osteotomy. The final cut splits the posterior column, starting where the iliac osteotomy ended, about a centimeter or so proximal to the pelvic brim. The use of an angled or curved chisel is often needed to complete the osteotomy, working medial to lateral in the posterior column to match the first cut. Here, a straight chisel heads down the posterior column with the ischial cut visible. The faint outline of a radiolucent retractor is seen along the quadrilateral plate. Distally, a curved or angled chisel is often utilized to join the posterior column and ischial cuts, completing the osteotomy. After all osteotomies have been made, the outline of the cuts may be visible at the right fluoroscopic obliquity. A Chance pin is inserted and functions as a joystick to assist in manipulation of the acetabular fragment and aids in reorientation and correction. Correction encompasses multiple maneuvers to address all aspects of the underlying deformity, improving anterior and lateral correction, medializing the femoral head, and restoring Shetton's line. Anteversion of the fragment helps avoid impingement. The preoperative motion is then compared to post-correction motion to confirm no impingement has been created from increasing coverage anteriorly. Provisional fixation is performed and X-rays are taken to assess coverage. Compared to preoperative radiographs, the lateral correction is appropriate with the tonus angle now under 5 degrees and the sourceal horizontal. The medial aspect of the femoral head is just lateral to the ilioischial line. Shetton's line has been restored and there's no crossover sign seen. The anterior and posterior walls are now appropriately balanced with the posterior wall now ending at the center of the femoral head. On oblique imaging, anterior coverage has been normalized. And at 90 degrees of hip flexion, no impingement occurs, and there was well over 20 degrees of internal rotation and flexion. Indications and technical challenges of the PAO side, the proof is always in the pudding. So what kind of results do the literature suggest we may anticipate from a PAO? At 9-year follow-up, 80% of patients reported good or excellent results. Risk factors for a suboptimal outcome included older age, with those over 35 years more likely to have progressed to total hip replacement, poor joint congruency, and joint space narrowing that was present preoperatively. Longer-term results out of Switzerland, published at 20 years follow-up, show continued encouraging results. 60% of hips had been preserved, although certainly signs of arthritis had become universal with longer-term follow-up. The 20-year follow-up data suggested that if no or minimal osteoarthritis was present, the outcome is going to likely be favorable. The vast majority of tonus grade 0 and 1 hips, 75%, were ultimately preserved at 20 years postoperatively. The authors concluded that the degree of osteoarthritis at the time of hip preserving surgery is the best predictor of outcome. Recent publication of 30-year follow-up data from the same group in Bern suggests that the life of a PAO may be finite. However, to take a glasses half full approach, a third of native hips remain preserved 3 decades after the index procedure. When accounting for the average age of 29 at the time that the PAO was performed, progressing to a primary joint replacement in the 5th or 6th decade is a resounding success and likely saved at least 2 cycles of arthroplasty. However, the authors also confirmed previous findings regarding the downside of early arthritic changes. When radiographic signs of joint space narrowing and subcondylar cysts begin to develop, the capability to preserve the hip for a long-term period is guarded. However, for a patient who may never need an arthroplasty revision, PAO may still represent a worthwhile endeavor in terms of quality of life if 10 or 15 years could be gained on a native hip before proceeding with arthroplasty. Age alone was one of the biggest predictors of failure in their study, although some patients over age 40 at the time of PAO still had not had any additional procedures at 30 years postoperatively. So what about the natural history of the dysplastic hip following PAO? Does the PAO actually delay the progression of arthritis or simply change things and make it look a little bit different? Results out of the anchor study group show that perhaps a PAO can delay the progression, especially if there are minimal degenerative changes present. For those that only had tonus grade 0 or 1 changes, the progression to total hip arthroplasty at 5 and 10 years was only 2 and 11%, quite low compared to those with tonus grade 2 changes, where progression to a total hip was 23% at 5 years and 53% at 10 years. Surgical complications are not uncommon after any procedure. Zaltz et al. Investigated the complications following periacetabular osteotomy by experienced hip preservation surgeons. The cohort had an average of 9 years of PAO experience. Minor complications included injury to the lateral femoral cutaneous nerve, and major complications included non-union, perineal nerve injury, blood loss requiring transfusion, and substantial heterotopic bone formation. Ultimately, 6% of patients required an unplanned return to the operating room, and 3 were treated for DVT. I told you we'd talk about some controversies as well, and certainly the management of borderline dysplasia fits there. The challenge that may arise is the term mild or borderline inherently suggests the diagnosis shouldn't be a problem. A minimally displaced fracture doesn't sound so bad until you learn it's in the femoral neck. I think of borderline or mild dysplasia similarly. The hip is a bad place to have a small problem. That being said, when diving deeper into their imaging, many of these hips that we would categorize as mild or perhaps only borderline dysplastic have other findings that suggest a more significant problem may be occurring. Nearly all borderline dysplastic hips had other radiographic features to suggest dysplasia, underscoring the reality that small differences we see on imaging still have the potential to lead to substantial degenerative changes in the hip. Take-home message, many parameters go into defining hip dysplasia, and certainly a lateral center edge angle is only one of them. So if you're still thinking, all right, Todd, this all sounds good and well, but what about a hip scope? Can't we just use something less invasive to fix the labrum? And the answer may be sort of, especially for someone that has mild dysplasia. It's maybe not an unreasonable approach. That being said, nearly a third of dysplastic hips ultimately went on to need additional procedures or had significantly worsened Harris hip scores, which was defined as failure in this series. The bottom line is that treating the underlying cause of the labral injury is much more likely to be successful in the long term than a Band-Aid style approach. The labrum and its role in dysplasia management is another area of controversy. One recent study evaluated whether labral tears present at the time of a PAO would put patients at a higher risk for a poor outcome. None of the patients underwent simultaneous labral repair, so this study was clean in terms of findings. The data suggested that treatment of the underlying dysplasia alone produced excellent results. Labral pathology is common with both impingement and dysplasia, with current thinking reflecting that an isolated labral repair without addressing the underlying cause, whether that be dysplasia or impingement, has a high probability of recurrence. It may be easier to think of the labrum as the innocent bystander in all of this. It's being asked to work overtime and do things it was not asked or designed to do when hip instability or impingement is present, analogous perhaps to the damage that occurs to the meniscus in an ACL deficient knee. Hip preservation is a rapidly evolving field, but at its really most basic level falls into two biomechanical problems: instability, as we just discussed, and impingement. Some biomechanical problems are a primary instability picture, i.e. hip dysplasia, while others may present with a more impingement-like picture. But the reality is that many of these problems coexist together. A thorough clinical and radiographic workup is going to be necessary so that any abnormal biomechanics are addressed before they lead to degenerative changes that are associated with a high probability of developing osteoarthritis in the hip. To conclude, hip pain in an adolescent or young adult should be investigated and potential causes ruled out. Well over half of hip replacements performed in patients under age 50 are secondary to hip dysplasia. The early, mid, and long-term results of PAO demonstrate quite good results and have certainly helped narrow the indications better to those patients without substantial degenerative changes. Controversy remains when it comes to determining how to address mild dysplasia and if associated femoral and intra-articular pathology needs to be addressed. Thank you for your time and attention this morning. Ryan and I would be happy to take any questions.
Thanks, Todd and Ryan. That was a fantastic talk. Maybe while people think about a few questions, I sort of prepared a few for you all. I was going to ask Ryan about the advanced imaging that he discussed. I noticed he talked about CTs and MR arthrograms, and I'm hearing sort of mixed messages about what is the best advanced imaging. Is it probably not a CT, but an MR with or without an arthrogram? What is your practice these days, and what do you recommend?
Yeah, so I'll take that one. I think that the answer is it depends, and it really depends on the presenting problem. For a lot of patients, they're going to end up with probably both a CT and an MR before any major reconstructive procedure these days, and I think that that trend has been something that a lot of people involved in hip preservation have moved to, which is if the goal is to sort of have one procedure that addresses all of the problems, you really want to have all of the data before you go in there. And so even if that means performing hip arthroscopy, an MRI to identify a labral tear or other intra-articular pathology is certainly very helpful, but understanding a little bit more as far as what the femoral version may be, and if there's associated femoral retroversion, that an isolated osteoplasty of the femoral head neck junction may be insufficient to totally treat the impingement. So to give you a sort of complicated answer to a simple question, I think most patients, in my mind, are going to have a clinical exam that will suggest a torsional abnormality or that will suggest something about their range of motion that doesn't seem to correlate with their radiographs. And so if the x-ray suggests and their clinical exam suggests there's something more complicated or perhaps more at play, then in my mind, an MRI is the place to start. And then before any major bony procedure, a CT scan is indicated to confirm if the clinical suspicion is high that there may be another source of deformity.
Hey, Todd, Greg Schmalley here. Yeah, great talk. Great job, Ryan, too. I'm wondering, how do you feel about injecting like a steroid at the time of the MR arthrogram and local to see if there's some response?
Yeah, no, I think that's a great idea. From my standpoint, it's very helpful to confirm intra-articular pathology with an injection of steroid into the hip, and certainly a little bit of local anesthesia at the same time. And so, if they are going to undergo an MR arthrogram, I have no problem with asking our radiologist to do that. I know they inject local at the time of arthrogram dye, and so that kind of gives me a little bit of input because I can ask them afterwards, hey, did you feel any better after the arthrogram? And the problem is so many patients have discomfort from the dye being injected that oftentimes the volume of dye causes such expansion of the capsule that they get irritation from that. So it becomes a little bit of a tricky way to tease out whether there is benefit from it. But in terms of confirming the pathology, I think that's one of the best things to do. The reality is that these are sometimes very complex patients that have had pain ongoing for a number of years. And there's many factors at play around the hip joint, many layers of soft tissue that could be at play as well. And so being able to confirm, hey, steroid injection improves symptoms tremendously for a period of time certainly gives confidence in the diagnosis, especially for someone that may only have mild or borderline radiographic signs of abnormality.
Hey, this is Vince. Ryan, great job. Todd, great job. How spherical and congruous do the head and the acetabulum have to be to reorient the acetabulum? If you have an oval and oval, then in weight bearing, they're congruous and they may hurt, but at least they're congruous. So if you then take an oval and you shift it over an oval, then you have very decreased contact in weight bearing. Not when the hip moves around to the congruous position, but in weight bearing. So how spherical does spherical have to be to do a PAO?
That's a great question. What you're getting at is Perthes-like deformities. So somebody that's had a history of AVN or that's had Perthes or that's had a condition that's resulted in a fairly substantial growth disturbance to the proximal femur.
What about DDH or DDH too that had?
Exactly, yeah, all of those conditions. And the reality is it's hard to answer that question because I think there's two problems at play. The first is that they're having abnormal loading on the hip joint. And even though they're congruous, and I think conventional thinking for years and years had been, well, as long as they're aspherically congruent, then who cares? The acetabulum's remodeled, no big deal. The reality, I think, that makes it a little bit more challenging is that there's still ongoing changes and abnormal load sharing that's occurring when you have uncoverage of a aspherical femoral head. And so I think that problem gets into a little bit more of a difficult scenario. And there's actually a trend now towards doing these procedures with, concomitant femoral osteotomies. That might even include reduction osteotomies of the femoral head to make a aspherical or ovoid or shaped femoral head more spherical. So that way it can accept a PAO better. And so I think that there's certainly some role in that opportunity to reshape the femoral head and the proximal femoral anatomy at the same time that you're addressing aspherical congruency. But that remains a challenge, there's no doubt.
I had another question about sort of the long-term implications of our earlier acetabular procedures, such as Salters and so forth, in terms of, has there been any sort of advance in understanding of, are we overcovering too many of these hips, or any other long-term implications you can discuss?
Yeah, that's a great question. Thank you, Clayton. I think, not to sort of dive too deeply into anecdotal information because that's not very helpful, but that's oftentimes what we have available. The reality is that a Salter osteotomy, I think historically has been one of the workhorse operations for treating infant, dysplasia, and the results in general are quite good. The downside is it's very hard to know, given that there's so much cartilage there when we're performing the procedure, how much of that cartilage is going to ossify and turn into bone and lead to impingement later. It's a question of how there's a lot of these hips that have had Salters and that have had Pembertons and other procedures that, data has suggested that maybe by their third or fourth decade, they've developed arthritis. And it's almost impossible to know whether that's from the index surgery, from the problem of hip dysplasia in a hip that was dislocated, or from a secondary cause of degenerative changes, i.e. impingement caused by a Salter that overcorrected. And so, without being able to sort of tease all those things out in a single study at 30 years retrospectively, I think it's hard to answer. That being said, I think there's a trend, and from talking to other people in the field, that essentially no Salter and no Pemberton, no pelvic osteotomy really should be done without an arthrogram now. And I think that data that you get from an arthrogram is very helpful when you're doing correction to make sure you're not overcorrecting. And so even though, the hip capsule may be relatively open, so to speak, you can still get enough dye in there to assess where the edge of the labrum is and to make sure that you're not iatrogenically over covering someone by performing a Salter. I think we probably historically have been maybe inadvertently over covering some patients that were having pelvic osteotomies, but it's hard to know. The reality is there's no way to confirm how much of that cartilage on log is going to ossify, especially for an older patient who's got fewer years left in growth. So it's a difficult question to answer, but it's certainly something we're studying.
So Todd, what is the learning curve? When iResults did that multi-expert review of complications, the complications were, reasonably small in number, significant in affecting the patient. But what's the learning curve? And for all the residents that are watching this now, thinking, wow, what a cool operation, I can do that one. What is the learning curve? How many do you have to do under supervision before you're out there on your own?
Great question. There is one paper that's been published on this. Woody Sankar and Eduardo Novaes, who are two of my mentors, spent time essentially doing a hip preservation training. And so the average number of PAOs that they had done in their fellowship was about 40 to 50. And so in their training, they had done 40 to 50. And then they looked at their first 20 PAOs in practice compared to their second 20 PAOs in practice, and they found no difference in terms of complications. So they concluded that by having a specific training regimen where you can get under your belt at least 40 or 50 PAOs, that you're more likely to have comfort in performing the procedure, identifying potential pitfalls and preventing complications. But there's been no study that's been able to document that X number of PAOs is necessary before you are signed off on it or that you're comfortable doing it. I think that like any procedure in orthopedics, having people around, mentors and people that you can go to, both that are comfortable with the procedure and that can also help you out in a pinch intraoperatively is very helpful. That guidance and mentorship is something that is important anywhere in any procedure, and no different in a PAO for sure.
Thanks.
And so Todd, you mentioned labral tears associated with hip dysplasia, but you didn't really specify how many got better just with the PAOs. I've always heard about 85% get better. Is that number accurate? And is there a role for doing a concomitant arthrotomy and trying to repair the labrum while you're there? Is that something you routinely advocate for when there's a known labral tear?
Yeah, so I completely agree with data. In fact, it may even be higher than 85%. I think the latest literature that's out there suggests almost 90 to 95% of patients that have labral tears. The problem with is the definition of a labral tear. So, undersurface fraying, which is probably present in 50% of people that have no hip pain at all, is considered a labral tear, just as complete labral separation from the contralabral junction. So they get lumped together, and so it's difficult to ascertain which tears may be necessary to repair, which tears perhaps are insignificant, are not as big of a deal. And so that's the first kind of problem in evaluating the data. The reality is that in the majority of these patients, once the labrum is offloaded and basically put back in its normal anatomic home, the symptoms that were occurring tend to resolve. And so, if you were to obtain MRIs on most people age 40 and older, probably well over half of them would be asymptomatic with labral pathology. And so I think the general thought has been labral tears are something that need to find an underlying cause for, and whether that's impingement or whether that's instability or a combination of the two, and that should be addressed. And so if there's associated impingement, then I think addressing the impingement and the labral pathology is certainly required at the time of a PAO. If there's no associated impingement in a labral tear, seems more like just small undersurface fraying, then probably not as critical. The incidence of arthrotomy at the time of PAO depends on what center you're at. And some centers, 80% plus of patients have an arthrotomy at the time of PAO. Lately, there's been a trend towards trying to add on and do an arthroscopy prior to PAO, and depending on if that's something that's a skill set that the open PAO surgeon has the ability to do, or whether that requires a second surgeon, certainly increases the complexity of some of the challenges from a logistics standpoint. But to be blunt, I think the answer is it depends, and it really depends on probably the age of the patient and whether there's associated impingement. And if it's a relatively older patient without much impingement, I probably wouldn't get too worked up about the labrum. If it's a younger patient with associated impingement, I think it's probably more critical to address at the time of the PAO or prior to PAO. That being said, if only 5 to 10% are having symptoms after a PAO, you could certainly justify just operating on those that need it down the road.
I'm not hearing any more questions.
Actually, so Ryan, what was your takeaway from this? I assume that you're interested in this field of orthopedics. What was your takeaway from this whole thing?
I think at least for delving into my kind of portion of the talk is these assessing the deformity. I learned quite a bit about really assessing the deformity in these patients, and it can be quite complex. It's not just a upsloping, shallow acetabulum. There's quite a bit that goes into it. So I think I really learned a lot in regards to that.
Yeah. So and so when you were rotating with us here, you saw us doing all these well-intended but maybe inappropriate procedures as came, Salter. So I trained with Salter in Toronto, and that used to be the absolute answer to life. It was just the answer to life. And he used to debate with Pemberton all the time decades ago about, do you fold the acetabulum, do you redirect the acetabulum? And Salter really for many years reported, and others reported, really good outcomes of reorienting a maloriented acetabulum. And now the most recent stuff coming out about, wow, have we been overdoing some? What are really the indications for doing them at all? Should you just wait? If there's some, quote, two-dimensional dysplasia on an x-ray, do you just wait until they're 16 or 20 and then do this gigantic operation? Or do the more simple Salter's pretty simple operation? And it seemed that most of the patients did pretty well, though now further evaluation says maybe not as well as we thought they were going to do. So are those the things that came up in your reading too? Do we just wait for the PAO, or do we do the Salter and hope that most will do well?
Yeah, boy, I don't know if I know the answer to that,
Okay.
that question. Yes.
Yeah, but those are the questions being asked, and your generation is going to help answer them. You looked at the data too. When did the Americans, not Gans, but when did the Americans really start embracing this idea about reorienting the acetabulum in an older, not a 5-year-old, but an older individual? How long ago was that?
It seemed 20, 25 years or so. It seemed like late 90s, early 2000s when most of the papers started being published from the US.
Yeah, that's been my impression too. Is that, Todd, is that about, it's only been about 20 years, right?
Yeah, I mean, I can't say this for certain, but I would think if you trace the lineage back when Millis, right, trained with Wagner and these guys and Gans, he really brought it back to North America. So, and that was in the late 90s, I believe. Right. Yeah. And so when he brought it back to North America, and then you can trace almost everyone that does PAOs that's been in practice for 20 years has some connection probably to training under Millis, which is quite a feat. And so to a certain extent, Jeff Mass, who trained under Gans as well, was another lineage, but all from the same sort of common pathway, which is, you've got one person in Switzerland doing a procedure and lots of people learning from them, and the family tree from there grows.
Great.
Do you have any more questions? We have a few more minutes. Well, in light of the silence on Zoom, I will take that as no more questions. I'd like to thank Todd and Ryan for great grand rounds. And I think it's fair to say that Todd is accepting referrals to Seattle Children's for both adolescents and probably young adults, huh, Todd? Even
Absolutely.
20s. So keep that in mind as you see these patients, and if you're not comfortable doing taking care of them yourself. So again, thanks you guys, and we look forward to seeing everyone next month at our grand rounds for the University of Washington Department of Orthopedics. Thank you.